In this module, we'll discuss what makes a study unreliable or poor. Any of 7 or more features of a study can disqualify it as being reliable, therefore making it unreliable. The reasons for unreliability can be summarized as follows. Selection bias cannot be discounted. This occurs when subjects are included or excluded based on exposure or outcomes. Information bias is likely. This means that information on exposure or health outcomes is not obtained in the same manner for exposed or non-exposed subjects. There is plausible confounding. This could occur when smoking status is not known and there are plausible differences by dose categories, or when there is no attempt to adjust for socioeconomic status. There is no dosimetry or it's a poor quality. This is the kiss of death that makes a study unreliable, non-interpretable. The participation, follow-up, and outcome determinations are severely incomplete and different by exposure status. This occurs when the study population is not well defined, when the comparison group is not comparable, when participation rates or follow-up rates are abysmal, or when outcome determination is poor and not comparable by exposure status. Unreliability can be seen when the focus is on subgroups and cherry-picked results, and not on the full results or a priori and original hypotheses. Such results are often overinterpreted. Be wary when the study results are inconsistent and very different from those in the reliable studies. We have learned some things during the past 100 years to make judgments such as whether results are consistent with past reliable studies and to what extent they may be inconsistent. Now, an unreliable study doesn't necessarily mean that it's terribly flawed, just that the results are not dependable for one or for several of the reasons mentioned. But these characteristics are such that the study should be discounted when making judgments on health effects and when making decisions related to protection guidelines or to dose management. Let's talk about bias that has affected studies of a common procedure we are familiar with, CT exams. These studies fall into the unreliable category because of what's called reverse causation or confounding by indication. CT evaluations are important because so many people receive such examinations now in combination with PET procedures for medical imaging. The increase in use over time has been from 60 million exams per year just 10 years ago to now over 80 million exams per year. About 1 in 4 people in the United States might receive a CT this year. And it's not an inconsequential exposure. The dose from one imaging procedure, if medically needed, is not a reason for concern. However, 10 or 20 exams can result in a more meaningful accumulation of dose. There have been studies of children and CT exams that have raised concerns over possible health effects. Here's one of the studies published in The Lancet. It was a record linkage study of leukemia and brain cancer following CT exams for children under the age of 22. Large numbers were included, 178,000. There was no individual dosimetry in this study, yet the authors reported dose-response relationships and significant findings at very low doses. The estimates of radiation risk were remarkably high, particularly for brain cancer. These risk estimates are enormous. It would be surprising that other investigators would have missed such risks in other studies. Interestingly, the risk estimates are made for 1 gray, which is an extrapolation from low doses to much higher doses. It's usually the other way around. No child received even close to a gray. The charts are in milligray, and if you extrapolated the risk to a gray, it would literally be way off the charts. So these very high risks, among other epidemiologic inconsistencies, should give you pause and the studies scrutinized by scientific committees. And they were. But what does the United Nations and the National Council on Radiation Protection and Measurements, or the NCRP, say about this study? The major epidemiologic limitation is there is no information collected as to why the scans were performed. This potential for bias alone places the study in the unreliable category. As the NCRP concludes, children who receive frequent exams may have some underlying disability related to the outcome of interest. For example, a child who receives many CT exams of the head may have a central nervous system disorder that is prompting each exam that eventually results in a cancer diagnosis. This is called reverse causation because it's not the X-rays that cause the cancer, but the underlying condition that prompted or caused the X-rays. This is similar to confounding by indication, or when the symptoms prompting the X-ray are related to an as yet undiagnosed disorder. When children who are referred for a CT exam because of a suspicion of brain tumor are included in studies, an example of selection bias, the results are biased towards finding positive results. Another example of confounding by indication is a published study associating dental X-rays with meningiomas. The study was based on interviews asking patients with or without meningioma when and how many dental X-rays they had. Here's the problem. Meningiomas cause pain to the oral facial region right around the jaw. So if I had pain in my jaw, I'd assume it was a dental problem and go to my dentist and receive dental X-rays. The dental X-rays did not cause the meningiomas in this study, but rather the underlying tumor or the pre-symptoms caused the dental X-rays. There were a number of epidemiologic inconsistencies also, such as patients who had the most dental X-rays also had the lowest risk. Here's an example of reverse causation explaining a strong association in an epidemiologic study. It occurred in a reliable study that is referenced today as indicating that adults are at low risk of radiation-induced thyroid cancer. The study began in the 1980s, and it demonstrates reverse causation and not a hypothetical possibility. Sweden is a gold mine for epidemiologic studies because of their national registries of health. We studied 35,000 adults in Sweden where the dose to the thyroid from imaging examinations using radioactive iodine was almost 1 gray on average. The abstracted clinical data on all patients included age, sex, thyroid size, and amount of radioactive iodine administered, and the reason why the exam was given. There were a variety of reasons for an iodine 131 scan to be requested, such as hyperthyroidism, hypothyroidism, and suspicion of thyroid tumor or nodule. For all the reasons taken together, there was a statistically significant association, almost twofold, between radioactive iodine and thyroid cancer. We wanted to rush and report these findings. We'd be the first to demonstrate convincingly that radioactive iodine is a human carcinogen, even though the thyroid dose was received gradually over time. Radioactive iodine has an 8-day half-life, so the study would suggest that protracted radiation does not protect to the extent indicated in animal studies. We were a bit concerned, though, that no other study had ever found the adult thyroid gland to be susceptible to radiation-induced thyroid cancer. So we looked at the data a little bit more carefully. Here are the relative risks separated by the reasons why the exams were performed. All reasons, a significant 1.8 relative risk. Suspicion of a tumor, a whopping 3.5 relative risk. Other reasons, a low 0.9 relative risk or no excess risk at all. A relative risk of 1 indicates no elevation in risk. So once the patients with a suspicion for thyroid tumor were excluded, the purported high risk disappeared. It was not the radioactive iodine that caused the cancers, but rather the underlying tumor or the pre-symptoms that caused the radioactive iodine scan to be performed. The inclusion of those referred because of a suspicion of tumor biased the results to the high side. Without such knowledge, the results would have been published in a high-impact journal by well-known scientists from Sweden using impeccable methodologies, high-quality dosimetry, and significant results. And it would be wrong. So, not accounting for referrals because of the suspicion of a tumor can place a study from a reliable to an unreliable category. Now, going back to the CT studies, so many of us and our children receive CT exams. Why? They are of substantial medical benefit when indicated and properly performed. The medical community does not claim there is no risk, but rather that the medical benefit is substantial and far outweighs the theoretical future risk. Medical alliances, such as Image Gently, have been formed to continue to address improving the care of children and how to get the best image for diagnoses at the lowest dose. Manufacturers have improved the imaging machines to use lower doses and to have more control of doses, while continuing to focus on improved images for medical care. The CT studies were described by the authors as pediatric exposures, but the studies included patients who were under 22 years of age. When you picture pediatric exposures, do you think of young adults or even teenagers? Probably not. But where do you think the risk of brain tumor was concentrated in this study? Among the children? Children are more susceptible to radiation. Or among these older patients who are not even close to being as susceptible because their brains have stopped growing to a large extent. The results in the UK study are the opposite of what you would expect from other radiation studies. These excess relative risk, ERRs, of radiation for teenagers and young adults are peculiar. They are really high. And the kids under the age of 5 should have had the highest risk, but they had the lowest risk. The United Nations also stressed these implausible results, since susceptibility decreases as the brain development nears completion. Risk is always found to be highest under age 5 years at irradiation and largely disappears at the age of 20. Again, the epidemiologic pattern of risk by age at exposure is implausible. What about consistency? In Australia, they did a record linkage CT study of almost 700,000 children under age 20. This was published in the British Medical Journal. The comparison linkage group was with 10 million persons of comparable age. If you look carefully at the results, there's a problem. Excess cancers were reported for practically all cancers. Everything appeared elevated. This is remarkable and not seen in any radiation study of humans or even animals. Also, increased risks were found for cancers not known to be caused by radiation, like Hodgkin lymphoma and malignant melanoma. But there was one exception. Breast cancer was not increased, yet the breast is one of the most highly susceptible tissues, especially among adolescents. So let's pause a bit and consider another anomaly. Brain cancer were increased, But it didn't matter whether or not the brain was exposed. Brain cancer was increased for CTs of the brain and for CTs of other body organs, such as the abdomen. What does all this mean unless there are serious biases that limit the interpretation of this study? The United Nations review of early CT studies concluded that the risk occurred implausibly early. Radiation causes cancer, but not the next day or within a few years, except for leukemia. The risk estimates are not consistent with the Japanese study of children exposed to the atomic bombs. And then lack of information about indications for the CT scans indicates the potential for reverse causation. The cancers may have been caused by the medical conditions prompting the CT exams rather than by the CT dose. The lack of individual dosimetry is a serious flaw. In other words, these CT studies are plagued by the likelihood of reverse causation, the absence of individual dosimetry, and using assumptions that weren't validated. The epidemiologic features are implausible. A 2018 NCRP commentary evaluating epidemiologic studies classified these CT studies as inconclusive based on weaknesses in the epidemiologic methods and the absence of dosimetry. Thus, while the studies were published in high-quality journals by experienced investigators, they should be used with caution because of substantial weaknesses in design and dosimetry. Let's look at another study, Prenatal X-ray exposure in cancer in children, and why the association is still questioned as to whether or not it is causal. The fetus is considered more sensitive than the child, right? Not really. The extensive study of atomic bomb survivors indicate that the cancer risks for exposures of children under age 6 are greater than for fetal exposures. Further, the children exposed in utero among atomic bomb survivors did not show an elevation of childhood cancer. No cohort or follow-up study, in fact, finds an increased risk of childhood cancer following prenatal X-ray exposures. These include large studies in the United Kingdom of over 30,000 in utero exposed children and also large twin studies. Twins have a much higher frequency of prenatal X-rays than singletons. The only positive study for prenatal exposure are the case control interview studies. In such studies, the mothers of children who died from leukemia and other cancers are asked how many X-rays they had during pregnancy. Then you ask the same question to comparison mothers whose children did not die. The questions are asked several years after the pregnancies, and the responses are compared. Sometimes an attempt is made to validate with medical records the responses, but that's very difficult, particularly trying to evaluate responses such as, "I did not receive an X-ray." Here's the famous and high-quality Oxford prenatal X-ray study by Alice Stewart. Dr. Stewart was a very influential scientist. But similar to the Australian CT study, practically all childhood cancers are elevated. Perhaps equally remarkable is that the risks were all the same. That is, a 1.5-fold risk, a 50% relative increase associated with prenatal X-rays. No matter what the cancer, the risk is the same. Even for lymphoma, which has not been convincingly linked to radiation in any study. Radiation does cause acute lymphocytic leukemia, but not Hodgkin's lymphoma or other types of lymphoma. And then, Wilms tumor of the kidney is elevated. But Wilms tumor is an embryonic tumor, which means it develops in the first trimester. Elvimetry is an X-ray procedure to measure the birth canal to judge whether there might be difficulties with delivery. Elvimetry is performed just before birth in the last trimester. While these generalizations are not hard and fast, it remains difficult to understand how radiation could cause a tumor of embryonic origin following exposures after the embryonic stage, and then at the same level of risk as all the other cancers. Similarly, neuroblastoma is also an embryonic tumor, and it seems unlikely to be affected by late-stage X-rays. The International Commission on Radiological Protection looked at the Oxford study of childhood cancer and questioned whether the great consistency in the elevated risks of all cancers, including the embryonic tumors and the lymphomas, may be due to biases in the study rather than a causal association. Response bias is the likely explanation. That is, mothers whose children have died may have better memory recall than mothers of living children not affected by such a tragic event. So uncertainty still exists as to the biological plausibility of these results and find the same relative risk for all childhood cancer, including embryonic tumors. Even critics, however, do not discount the entire study, and particularly the results for leukemia. Over the years, actions have been taken to reduce prenatal X-ray exposures, including substituting with ultrasound exams. But the study should not be taken as strong evidence for low-dose radiation effects, and there should be an awareness of response and participation bias in case control interview studies.